lung cancer leads to 1 in 4 of all deaths caused by cancer. And we are in the unfortunate position where 29,800 Canadians will develop lung cancer this very year. And 1 in 15 people who live in Canada will develop lung cancer in their lifetime. This equates to 82 Canadians being diagnosed on a daily basis. And if you look at the biggest diagnostic cancers, lung cancer is at the top of the list for the most commonly diagnosed cancer in Canada. If we look at the current state of lung cancer in Canada, there is some good news. We were actually featured lung cancer, in the Canadian Cancer Society cancer statistics this year. And if we reflect back onto what the cancer statistics show, we actually see that the incidence, so that's the number of new cases diagnosed, as well as the mortality, so the number of people who lose their lives to lung cancer, has now been decreasing for both men and women. We've seen decrease in the number of new cases and the number of lung cancer deaths in men now for over 20 years. But it's only been more recently that we've seen this downturn in women, where it was in 2012 that the diagnosis rates started to go down, and it was in 2006 when the survival rate started to improve. If you look amongst Canadians younger than the age of 55, we actually see that there's a greater proportion of young women who are diagnosed with lung cancer than men. Now, for things that aren't so great, about half of all lung cancers are diagnosed at stage 4. This is cancers that have spread outside of the lung by and large, and these are generally considered incurable. On top of that, nearly 1 in 5 cases are diagnosed at stage 3, where you've got a cancer that is either quite large or a cancer that is spread to the lymph nodes in the center of the chest. This is what we call locally advanced lung cancer. So if you combine stage 3 and 4, cancers that have spread to lymph nodes or spread to other parts of the body, that's over 2/3 of all cancers diagnosed of the lung that are in locally advanced or metastatic stage. If you look at the late stages, it's actually more men than women who are diagnosed at stage 4, and it's the inverse with the earliest stages. More women are diagnosed than men at stage 1. And if we look across our great country, the highest rate of stage 4 lung cancers is actually found in the territories. So Nunavut has the highest rate of lung cancer, and the lowest rate for lung cancer in the provinces is Ontario. So what are Lung Cancer Canada's hopes and goals for lung cancer? So 1, we would like to increase overall lung cancer survivorship. 2, we look to a future where we can effectively treat lung cancer patients in real-time fashion and keep up with the latest breakthroughs. We would like to ensure that postal codes do not dictate the level of care Canadians receive, where everyone can achieve good, effective lung cancer care. And last but not least, we want to make sure that we bring our system of care up to pace with medical advancements, and we're not years behind our American colleagues to the south. So as part of our agenda today, we're going to be walking you through some of the key highlights of our Faces of Lung Cancer 2020 report. And you see the cover here. The features of our Faces of Lung Cancer report this year are threefold. One is around screening. Next is around early detection. And then last but not least, around the diagnostic phase and how we can make advances. So I'm going to forward to the agenda for today. So again, my name is Dr. Rosalind Juergens. I am the current chair of the Lung Cancer Canada Medical Advisory Committee, and I'm an associate professor at McMaster University. Our first speaker will be Dr. Stephen Lamb. He's a professor of medicine at the University of British Columbia and a member of our Medical Advisory Committee at Lung Cancer Canada, and he'll be speaking about screening. Next, we have the honor of a patient and caregiver, Shannon and Clayton Gall, who will be speaking about their journey. Next, we have Dr. Brandon Sheffield, one of our esteemed pathologists. He works at the William Osler Health System in Brampton, and he's going to be talking about strides in both testing and diagnosis. After the midpoint, we're going to have our president of Lung Cancer Canada, Dr. Paul Wheatley-Price. He's an associate professor at the University of Ottawa, and he's going to be talking about looking forward with a lung cancer diagnosis. We're then going to be hearing from one of our own colleagues, Dr. Kevin Zhao. He's a hemato-oncologist at the Hôpital du Sacré-Cœur in Montreal. He's been on the front lines of battling COVID in Montreal, and he's going to speak a bit about insights on what that's been like as a physician and lung cancer advocate working in Montreal. And then last but not least, we're going to discuss some survey results that we had conducted, results from a survey that we've conducted about COVID-19 and anxiety and stressors around COVID-19 with lung cancer. And one of our lung cancer survivors and patient advocates, Angus Pratt, is going to present those results. So I'm going to pass the screen back to Michelle, and we will move forward with our first speaker, again, Dr. Stephen Lamb. Stephen Lamb is a professor of medicine at the University of British Columbia. Just so for those of you who don't know him, he's a distinguished scientist in lung cancer research. He chairs the Pan-Canadian Lung Cancer Screening Network, and his research focus has been on early detection of lung cancer. He has received international awards for his work that he has done in lung cancer prevention research. So we're quite honored to have him as one of our speakers today. So Stephen, I will pass the controls to you.
Thank you, Dr. Jerkins. Good afternoon, everyone. I'm going to discuss the importance of lung cancer screening as a standard of care and highlight the current status of lung cancer screening in Canada. Next slide, please. So screening is very important. As we know, 58 Canadians die of lung cancer each day. So screening program will help to shift the lung cancer diagnosis to an early stage when curative treatment is still an option and when the likelihood of overall survivorship increases. So for example, without screening, about 30% of the lung cancer patients that we see have stage 1 or 2 lung cancer that are amenable to curative therapy. But 70% of them will have advanced lung cancer. So with screening, we can actually shift the proportion different. So instead of 30%, we can have 70% of patients with stage 1 and 2 lung cancer. So low-dose CT screening for those with at the highest risk can potentially help to save up to 12,000 lives per year. Next slide, please. So there are several things that the Canadian Partnership Against Cancer have been doing across Canada to facilitate planning and implementation of lung cancer screening in Canada. The first thing is, in collaboration with 11 Canadian jurisdictions, that they have developed a standard business case for the provinces and territories for use. They can adapt the standard business case according to their local context to advance lung cancer screening. The second thing is they have developed a toolkit to assess the readiness to implement lung cancer screening to help to utilize the business case. And the third thing is there's an OncoSim microsimulation model to help to plan the resources required for screening. So we can see this is the current picture across Canada. The different stages of implementation of screening across Canada. So 10 jurisdictions are in varying stages of implementation. So for example, some have created advisory committees and working groups, developed proposals and business cases. And there are 3 provinces, BC, Quebec, and Alberta, have Hospital or Cancer Foundation funded pilot studies under research protocol. And the province of Ontario is the first publicly funded province to have a pilot program in 4 sites in Ontario. So very recently, British Columbia announced the first organized lung cancer screening program in BC. Next slide, please. So in addition to these 3 things, the partnership has also provided seed funding to jurisdictions and professional organizations to plan and implement organized lung cancer screening programs. So these projects have a focus on equity to ensure First Nations, Inuit, and Métis people and other underserved groups, such as those living in remote area, to have access to high quality screening services. Next slide, please. So the critical final step is to move from a research study and pilot program to screening as a standard of care. But this requires government funding. But this will pay off over time because screening will become a far more cost-effective measure than treating patients with advanced stage cancer. Next slide, please. So British Columbia took action on this. So in September 14th, the Premier John Horgan and Minister Adrian Dix announced that British Columbia will commit to an organized lung cancer screening program to roll out in 2022. So BC will become the first formal program in Canada similar to colorectal, mammography, or cervical screening. Now, you may wonder why it takes a year to roll out the screening program across the province. There are lots of infrastructure that is needed in order to roll out the screening program. For example, we need the IT infrastructure to link all the screening sites, to have people to do risk assessment, to do quality assurance for the screening sites, very similar to mammography, to certify radiologists to do the reading, have a standard reporting and management protocol. To establish infrastructure costs some money, and that's why we are very grateful for people like Shannon and Clayton Gall to donate generously to help us to establish the infrastructure to roll out the screening program in BC in 2022. So I would like to turn over to Shannon and Clayton to share the story with you about Shannon's cancer journey.
Come on.
Dr. Jerkins?
Yeah.
You with us?
No, I was just, the galls are muted.
Oh, the galls are muted. Oh my goodness.
Our apologies, everybody. There we go.
I think we're good. All right.
There, we got you back.
Okay.
Okay.
Great. Well, hello, everyone, and thank you for inviting us to speak today. My name is Clayton Gall, and this is my wife, Shannon. We'll be talking to you about our family's experience with lung cancer and how we became in advocating for better outcomes.
Clayton and I have lived in Kelowna, BC for the last 10 years. Before that, we were in Toronto for 12 years. We first met in 1994 in Vancouver at an investment management firm called Phillips, Hager and North.
Most people just call it PH&N. I've worked at PH&N for over 29 years, and I don't think it's possible to describe the impact that the firm has had on my life and on Shannon's, but it's fair to say that PH&N is like family to us.
I was diagnosed with stage 4 non-small cell lung cancer in September of 2018, after several months of nagging back pain. This diagnosis completely rocked our world. I've never smoked. I was quite active and was busy raising our 2 young children. Within 2 weeks, I was having radiation therapy on my back, followed by surgery to remove tumor from one of my ovaries. I was enrolled in BC Cancer's personal oncogenomics program and found out that I am EGFR positive.
Shannon has been taking Tagrisso since November 2018. And while she still has some nagging back pain, really she's experienced minimal side effects from her treatment. Last year, Shannon spoke at a BC Cancer Foundation event to help raise funds for the study of genomics. Retired PHNN colleagues stepped up in a big way to show us their support.
It felt great to be able to contribute back in a positive way to the fight against cancer. And in June of 2020, we had a conversation with the BC Cancer Foundation. They sent us a proposal to help fund a province-wide lung cancer screening initiative. The fundraising goal of this initiative was $1 million. Clayton and I provided some feedback, but after a few days thinking about it, we contacted them and asked them if they would give us a chance to raise the entire amount.
Shannon wrote a series of emails to retired and current colleagues of ours at Phillips Hager and North. Most of them had heard about Shannon's diagnosis, but for others, it was the first time we had any contact with them in a few years. We made a personal donation and asked them to match or beat it, and within 2 weeks, we had raised $500,000.
Each email was personalized to reflect our experience with lung cancer and our relationship with the potential donor. However, the main gist of the communication stressed the importance of screening for lung cancer. We highlighted other screening practices such as a Pap test and mammograms. We stressed how many lives could potentially be saved and the unfortunate reality of just how many people will be diagnosed with lung cancer.
And we talked about how a screening program will help diagnose lung cancer in stage 1 or 2 when it's treatable, how this will save money in the long term, and how cancer research and treatments overall to become much more successful.
Our message resonated with our PHNN family. Within 2 months, we reached our $1 million goal. Shortly after, as Dr. Lamb said, on September 14th, I spoke at a Government of BC government press conference with Premier Horgan and Health Minister Dix to announce that BC would be the first province in Canada to launch a province-wide lung cancer screening program.
Shannon and I will continue to advocate for lung cancer awareness and early detection. We are incredibly grateful to our PHNN family for coming together to raise $1 million and helping to launch this screening program. We know it will save lives, and it will be a legacy that our kids can be proud of.
So thank you so much for listening to our story. We believe that each of you can influence your local health authority and your government to implement a similar screening program. On behalf of lung cancer patients and their families, we want to thank each of you for your passion and dedication to fighting this disease. Thank you.
Thank you.
Oh, thank you so much, Shannon and Clayton. You gave me goosebumps. We are absolutely grateful for the efforts that you've put forth in helping move things forward in BC, and we hope that the rest of the provinces will take note and move forward. So we're going to move on to our next speaker. I'm very excited to have Dr. Brandon Sheffield, as I mentioned, from William Osler in Brampton, and he's going to talk about molecular testing and the wave of the future. Thank you very much, Brandon.
Thanks so much, Dr. Jurgens. So my name is Brandon Sheffield. I'm a pathologist or a laboratory physician, and I am a lung cancer doctor, but we don't see most lung cancer patients. So this is my office that we're actually sitting in right now, and it looks just like the office of any other pathologist. And somewhere between 40 to 50 patients will come through here every day. But not the way you'd think. We look at them mostly like this. This is a microscope slide, and it contains a tiny little piece of tissue that would have been taken in the form of a biopsy. And we look at that under a microscope and make a diagnosis, and we write reports to your surgeons, to your oncologists, and to the radiologists to help them steer you in the right direction in terms of your treatment. So I just wanted to show a couple pictures. The one that's up right now, this is the office where I trained to become a pathologist. It looks very much the same as the one that will spend the next 30 years sitting in, hopefully. If we could get the next picture. This is Dr. Pierre Masson, one of the first Canadian pathologists. You can see nothing's really changed that much. Our microscope looks very sophisticated, but the technology is well over 100 years old. And we're still using the same principles to diagnose patients today as we were using in the late 1800s. Can I have the next slide? So this is a typical lung cancer sample. You can see it on the left-hand side of your screen. It's very challenging to come up with a diagnosis and also get these genetic tests like EGFR and others because of how small they are. You can see, just for comparison, the one on the right side of the screen is what an average breast cancer biopsy looks like. So a lung cancer sample is often about 1/100th the size even of a breast cancer sample. If you get the next slide. These are two of my colleagues who I just wanted to show you in the interest of faces of lung cancer. On the left, this is Fiona. She's a laboratory technologist and she's preparing a lung cancer sample to be viewed under the microscope. And on the right-hand side, this is Ludmila. She's cutting a lung cancer sample into microscope slides, and each one is about 4/1000ths of a millimeter thick. And she's using a machine that is not unlike the deli slicer that you see at the grocery store, except it works with a lot more precision. And we all know that when you go for a medical procedure, you want to choose a physician or a surgeon that you're very comfortable with, that has very good hands. Next slide, please. And Luke, oh, one back. Oh, it got cut out. I'm very sorry. But what I would have liked to show you is a close-up of Ludmila's hands, because she is the very best in the business. And when a sample is very, very small, no healthcare worker other than her is allowed to touch it, because she's the only one who can guarantee that we get a diagnosis and all of those biomarker results on every single sample. So these guys brave the pandemic every day to come to work to help lung cancer patients, and they're happy to do it. I just wanted to make sure they got included in this. You can go to the next slide, and just to show that life for technologists really hasn't changed that much either in the past 100 years. Next slide. But the diagnosis of lung cancer has very much changed. So looking down a microscope is really not sufficient anymore to give patients and their doctors the answers that they need in order to treat their disease. So this is a modern day classification of lung cancer. And just like EGFR, there are dozens of other driver events that we can't see under the microscope. So we're busy now adopting our practice to try and use some more sophisticated methods to get the underlying genomics and driver events out of those small, tiny samples, get the information to your oncologist so that they can translate it into a treatment. Can I have the next slide? So these are our technologists with our new next generation gene sequencer. This is a technology that traditionally hasn't been in hospital laboratories, but it's something that is very necessary for the management and treatment of lung cancer in 2020 and forward. So this is a piece of technology actually that our technologists here were instrumental in bringing this in. They saw how badly lung cancer patients needed it, and they really advocated to get this in. They took a risk and changed their day-to-day practice and learned a whole new modality that they'd never been trained in before. The workflows were very long and caused them to work overtime and run through their shifts, and really a lot of burden on them, but they were happy to do it. And you can't tell under their SARS masks, but they're all smiling very much. And with their help, I can show you here, this is a gene sequencing microchip. And a lot of the work that we do now actually happens on these. So this is where next gen sequencing happens. All the chemistry happens inside of these microchips, and then we can examine the results on our computers to take a little bit of a deeper dive into lung cancer. So thank you very much, everybody, for your support. And keep in mind that your pathologists and the team that supports them are always here behind the scenes. And just like the other physicians that you meet on a day-to-day, we're working very hard to take care of lung cancer, this disease, and to try and find some solutions that'll improve the lives of those living with lung cancer. So thanks again.
Thank you so much, Dr. Sheffield, and thank you for everything that you do and the great advances that you've brought forth to your neck of the woods. Again, you've set the bar not differently than Dr. Lamb for how the rest of us should practice across the country in advocating for early testing and quick turnaround for our patients. Our next speaker is going to be Dr. Kevin Zhao. Kevin is an adjunct professor at the University of Montreal, and he's been on the front lines of COVID. So Kevin, why don't you tell us a little bit about what life has been like, not getting to be a medical oncologist, but getting to be in the throes of managing COVID-19.
Sure, just hopefully get control of the slides. There are slides that exist. There you go. So am I in control, or am I?
I think we are doing next slide for us.
Okay, we're doing next slide. So I'll be saying that a lot. So thank you very much. I'm quite humbled to be asked to speak for the first time before you, and I'm very grateful. Next slide. Oops, yeah, that was the next slide. So several apologies. One of them is that I'm definitely not going to be doing this in 5 minutes. It's going to be a little bit longer, so bear with me. And I know I've been asked to talk about COVID because it's the topic du jour, and particularly since I was in a COVID ward. But I apologize also to the fact that I want to make it clear that I'm only one of many healthcare professionals across the country, and I consider not what I've done here in Quebec solely to be on the front line. I consider all of the nurses, doctors across the country who are treating patients to be on the front line, because COVID is everywhere. And I want to acknowledge the work that has been done and that is continuing to be done for what has been probably the biggest challenge outside of cancer that we have to deal with, that we faced to date. And the last little line is particularly true, as many of you probably already feel. I think in Quebec we're particularly adept at saying that we are super sick and tired of talking about COVID. And as you can see on the right, the little rainbow that was popping up on all the windows everywhere, it became a little bit irritating to see, just because things weren't going well, and things are still on the way of trying to figure things out. So hopefully I won't be too irritable when I talk about the COVID situation in Quebec, because we're still in pretty much a big storm. Next slide. So just to give you some context, as you know, Quebec as a province, we like to do things differently. So one of the things that we've been doing with COVID is doing things badly. We have been one of the worst provinces, not only in terms of the number of cases diagnosed, but also in terms of number of deaths as well. And a lot of that was seen mainly in the long-term care facilities. On the right, it's a map of Montreal. So if you can think of Quebec as the epicenter of COVID in Canada, well, Montreal was the epicenter of COVID in Quebec. And where you can see the red spots, that's where the biggest, highest numbers of COVID were found in Canada. There should be a little star where you can see Ahuntsic-Cartierville. That's where my hospital is. And my territory actually covers a big chunk of the red spots. And it doesn't even include Laval, which was also pretty much hard hit. Next slide. There's a star with my hospital and the territory code. So back in February, as many of you were probably watching on TV, where we're seeing things how we're going in France and Spain and Italy and all the devastation that was happening there. We weren't yet being hit, so we were just sort of watching the storm from afar without really knowing what was going to go on. Next slide. And then the storm hit. So by April, it was becoming quite clear that COVID was starting to take hold in the province of Quebec, and particularly in Montreal. The worst centers that were being hit were obviously the long-term care facilities. The nurses and the patient attendants were all getting sick, and there was actually a deficit of almost 10,000 healthcare workers in these centers, to the point where François Legault, our Prime Minister, was actually begging and pleading for medical specialists, even almost decreeing that we should go into these long-term care facilities actually to abandon our practice and to help out and where some of the most sickest patients with COVID were. And on the right is actually a scene from one of the long-term care facilities, actually is in front of my son's daycare, which was one of the worst hit in terms of deaths. So I can guarantee you that this was a real situation, and it was actually a quite scary one back in February. Next slide, April. And then it started hitting at the same time our hospital. So this is my hospital on the left. We unfortunately made the undistinguished distinction of being the first hospital to get a inpatient COVID patient COVID positive. As you can see on the right, these are very old and antiquated rooms where there is no separation between patients. So we had entire wards becoming COVID positive in a matter of days. And we also realized with time that our healthcare professionals were actually bringing COVID into the hospitals. They were asymptomatic. They were spreading it from patient to patient. Patients were spreading them to patient. So our entire COVID ward at one point, our entire oncology ward, sorry, was being contaminated with COVID, which was a very, very scary thing for us. Next slide. So as you can tell, this had a dramatic effect on our hospital, not just mine, but many of the hospitals across Montreal and Quebec. So there were urgent actions that were asked of us to do. One was, how can we protect not only patients, but our nursing staff and doctors? Well, that was to do everything we could to not have patients come to the hospital. On many levels, we were asked to decrease the amount of patients that had to come for their treatments. We were asked to reduce our patient treatments by about 30 to 40%. We already had a waiting list that was actually quite extensive. We did this by changing our immunotherapies every 6 weeks, chemos every 4 weeks if we could. But it also came down to, did patients warrant chemotherapy at the risk of getting COVID? That was discussions that we were talking about, both in the adjuvant chemotherapy setting, but even in the palliative care setting. What was worse, getting COVID or getting their chemotherapy, and the risk, or not getting their chemotherapy? So that was those were very difficult and very strange discussions that we were having. We had to discuss code status all of a sudden, and to do that by telephone sometimes was quite uncomfortable. We also had to obviously reduce the amount of patients coming to hospital for inpatient visits. Telemedicine obviously became a huge tool for us, although I would argue that is probably not the best tool for all patients. But we also had to cut down on scans. So scans that were perhaps not judged urgent, you know, your follow-up scan every 3 months, they were also canceled and only reserved for the very, very urgent cases. And I can tell you, and having heard a lot from my patients, some of them actually felt let down by the system because of this. And this was something that was quite difficult to sort of argue for in the context of the risks of COVID, but in retrospect probably was a little too much. And one of the last things I would say was hard to do in terms of reducing patients and people to the hospital was no visitors were allowed to accompany patients, both for their new consults, for their newly diagnosed cancers, which is always tough. You always like to have support with you, but also patients who were hospitalized, and some of them were in palliative care who couldn't have visits, which was devastating for some patients. Next slide. And other things that we installed, well, obviously, you know, our tumor boards, which were there for normally discussing treatment and how would we treat patients. Well, they became, how do we prioritize cancer surgeries? Who would get surgeries? Is it worth it to get surgery in the context of patients might needing to go to the ICU, or the ICU already being overloaded with COVID cases, or the risks of getting surgery and then getting COVID afterwards, which was something that we never really had to deal with before. Our bronchoscopy suites were reduced by 90% because that generated aerosols, and the same thing for pulmonary function tests. So some patients couldn't get their diagnosis of cancer and had to be delayed by several months. We also had the added problems of reduced staffing. We had many nurses who were catching COVID day after day, as well as doctors. So that reduced our ability to treat patients properly. And that forced us to create what we called hot and cold zones. So there are places where you can be, where you're thought to be safe from COVID, And then you were not allowed to go to other places in the hospitals that were considered more hot. So I had several patients who normally see me when they're hospitalized. I couldn't, and they found that to be very difficult. And as also being director of medical research at my hospital, we had to shut down clinical research for about 3 or 4 months, which was devastating, obviously, for some patients who rely on clinical trials for essential treatments. And as you can imagine, the damage that could have caused, we're only going to see that as time goes on. Next slide. And so then the question is, did we overreact? Was this something that was real? And this was a study that we published this year with the help of my colleagues from the CHUM and other centers in the hospital and even BC, where, as you can see, the red line on the curve on the left was the patients who got COVID but were who were hospitalized, and they had a less chance of survival than those who got COVID and were in an outpatient. So I think a lot of the measures that we took, at least early on, were justified. I think we had to be very, very careful, and especially when you're dealing with something that's unknown and scary, I think it's best to be more prudent. But as I'll allude to in the next few slides, I think the collateral damage is something we can't calculate just yet. Next slide.
Kevin, we're going to have to get on to the patient COVID survey. So maybe if you could give us last thoughts.
Yeah. So why don't we just go to the last slide, and it's just basically my perspective. There
it is.
Yeah, there it is. The last before
the previous last slide.
Sorry about that. I'm sort of rambling on. So I think there are a couple of positives and negatives. I really will make the segue for Angus and talking about COVID anxiety, but I think there are a couple of things I do want to point out. I think there are a couple of things that were positives. Telemedicine, I think, is something that allowed us to be able to treat the most amount of patients in the limited resources that we have. It shows that we can adapt not only our treatments, but our ability to reach out to patients. Living with cancer and COVID is a message I think that I want to transmit, and I think it's very, very possible and very feasible. There are a couple of negatives. I do miss seeing my patients. I do miss seeing all of you. I wish I was doing this in person, obviously. And just to give a little segue to the next presentation, COVID stress and anxiety is real. And I think most of you who are at home probably see it every day as the number of cases are rising. And it's something that should not be shushed and ignored. I think that's something that we need to talk about. And as for the collateral damage, well, that's only time will tell. But thanks for listening to me ramble on, and I'll pass it on to
Thank you so much, Kevin. So we're going to pass the microphone to Angus Pratt. He's going to be presenting the results of a recent survey that we did about lung cancer patient anxiety and COVID-19. Thank you so much, Angus, for volunteering to do this for us.
I was voluntold. First of all, let me apologize in advance for my isolation cat. He is keeping me sane, but he also knows as soon as I start talking on Zoom, it's his sign for me to try and keep him calm. I want to begin he's actually going to make an appearance.
There you go.
Really, he's my oxytocin inducer. That's the way we need to think about him. Thank you, first of all, for trusting me with the responsibility of reporting on this marvelous piece of collaborative work. Both the staff of Lung Cancer Canada and my fellow patients have really done an interesting job, and I'm really grateful for their enthusiasm and for their help. So thanks to the caregivers and to the patients who've participated in this survey. Our objective was simple. We wanted to know if COVID-19 was impacting lung cancer patients and their anxiety levels. The unique part of this study was that we involved patients in designing and executing the survey. We first of all involved them in a roundtable to gather qualitative input. Then we used that to develop a digital quantitative survey. And we finally brought a focus group back to reflect on the data gathered. So we basically iterated over this objective multiple times. So what did we learn? The study is ongoing, and we recently fielded it again. There is some descriptive information that's emerging already. Patients are slightly anxious about the impact of COVID, and maybe slightly is underplaying it, really. But the interesting part of it is that when we examine the feelings of anxiety, they seem to be dominated by two: isolation and vulnerability. For those of us who were patients, this really resonated with us. When we examined the impacts of COVID-19 on patients' lives, the largest impact was seen in the ability to participate in life events with those that they love. While this is a common theme for many others impacted by the pandemic, it's particularly poignant for lung cancer patients, given the fact that many of us are terminal. The loss of this ability seems to raise anxiety levels tremendously. The final aspect of the survey looked at the supports. Again, the clear consensus of the data was the importance of clear communication from the healthcare team. I want to just divert though. It's one thing for me to present the data, but I'd like to take just a moment to speak to this personally as a patient, a perspective we often don't hear in our Canadian medical system. When my oncologist spoke to me about my vulnerability, it was a revelation to me. I wasn't immunocompromised. In fact, I'm in remarkable physical shape. I ran 7.5 kilometers on Saturday night. But because of the damage that's been done to my lungs by chemoradiation, I am vulnerable. So a couple of weeks ago, when I went to pick up a parcel at the post office, and then I learned the next day that there was an employee there who had tested positive for COVID-19, that has a huge impact on me. I spent the next 2 weeks checking my temperature and smelling things, because I've been told that's the earliest warning sign that we have, to find out if I had gotten this disease. That vulnerability leads to isolation. For example, when my son was working in the city for a few months, he had to return to Edmonton eventually, and we had a big debate about whether it was safe for him to give me a hug before he left. And we did, just for the record. But I may never see him again. And so those are the kinds of things that cancer patients are facing and the kind of decisions that we're making. That's a pretty downer kind of note to end on. And what I'd like to do is try and end on a more hopeful note with a poem that I wrote several months ago. It's trying to capture some of the hope in this brave new virtual world. It's based on a quote from Dr. Jack West from San Diego. He was talking about the transition that virtual medicine is making from bedside to website. And this is the perspective. So my poem is called Bedside to Website. We've talked virtual medicine for years. Now overnight, we are thrust from rich 3 dimensions with live body motions to flat, disconnected, hard to read thoughts and technology glitches. Where is the comforting touch and the steadying hand, the Kleenex for tears? How do I bring my bedside manner to an unreal world? Learn to connect through this flat screen and tinny voice. Deep breaths and grounded before I start. Eye contact through the camera and not the screen. Exaggerated movement and tiny, let me begin that sentence again. Exaggerated movement and careful words acknowledge the weeping I see. Breaking bad news in the gentlest way. I'm sorry, there is progression. The cancer is growing again. You don't have long now. And then one day, I know this world is mine, when she says, thank you for sitting with me and hearing my fears. Though we are miles apart, it feels like you're here at my side as we twinkle wave goodbye. Thank you.
Thank you so much, Angus, for those moving words and your tales of the survey and your own personal tales. We really appreciate the personal touch. I'm now going to pass the microphone over to my partner in crime, Dr. Paul Wheatley-Price. He's the president of Lung Cancer Canada, and he's going to be speaking about looking forward.
Thank you, Roz, and thank you to all the speakers so far. I'm going to try, Angus, and take your advice and look into the camera and not at the screen. I would ask you to pay your attention to the Lung Cancer Canada website, to the Faces of Lung Cancer report, which is now being released today and will be sent to you. And there are 3 primary messages coming out of the Faces of Lung Cancer report, and you've heard elements of those today from Dr. Lamb and Dr. Sheffield in particular. But Lung Cancer Canada really believes we need to push forward now with lung cancer screening and implementation of that in every province and territory across the country, with the potential to save hundreds and thousands of lives. We believe that the kind of testing that Dr. Sheffield so eloquently described should be available in a timely manner for every lung cancer patient diagnosed across the country, regardless of whether you are seeing your oncologist and surgeon in a well-known famous cancer center or whether you're in a smaller community or regional hospital. And we believe that access to new treatments is something that all patients should be able to get also in a timely manner, that we can get exciting new treatments through our regulatory processes in a quick way. And Lung Cancer Canada is pushing for all of those things. At the back of the Faces of Lung Cancer report, in the conclusion section, you'll see these Lung Cancer Canada believes summary statements. You can take those and use them if you would like to help us advocating for these issues with local, provincial, and national regulators and politicians. And together we can do that. And Christina in a minute is going to tell you about how you can join the Hope Army to do that. Some of the speakers you've heard, including Dr. Zhao and Dr. Sheffield, will also be on accompanying podcasts on the Lung Cancer Voices podcast, will be released later this month to go alongside the Faces of Lung Cancer report. There'll also be a podcast with the Canadian Partnership Against Cancer, who have been coordinating the lead for lung cancer screening as outlined by Stephen Lamb earlier. Regarding COVID, of course, it's a big thing that you've just heard from Dr. Zhao. And I would encourage you, if you are a patient or a caregiver or a family member of somebody with lung cancer, you know, speaking on behalf of the hospitals and the professionals, we're open for business. And if you're not feeling well or you do have concerns, please do seek medical attention. Don't avoid that for fear of COVID. Hospitals are well equipped and safe places now to be assessed. So if you are feeling anxious about your health, please do seek medical attention. This is the beginning of Lung Cancer Awareness Month for Lung Cancer Canada. There's lots of other things coming along, and I'm going to pass over to Christina Sitt, who is our fabulous programs manager for Lung Cancer Canada, and she's going to take you through the Hope Army and some of the exciting events and new initiatives that we've got coming this month. So thank you all for listening.
And welcome, Christina.
Thank you very much, Paul. And I want to start by thanking everyone that was involved with putting together our Faces of Lung Cancer report, starting with our patients. Really our patient stories that you'll find in the report that it was just sent to you underscore the importance of those advocacy policy points that Paul just mentioned. You know, Graham Hymas's story really underscores the importance of screening. And Anne Ulop, who's from Nova Scotia, she really is a story of why molecular testing is important and how her test results came in just in time so that she was able to get the right medicine and a targeted therapy as opposed to an IV or chemotherapy. And Tracy's story really talks about the importance of access to medication. I mean, she had her friends GoFundMe in order to be able to have access to medication. And really, lung cancer, as I think we will all agree, I'm sure, is not a GoFundMe disease. So check out the Faces of Lung Cancer report. It is being sent to your inbox now. And as part of our Lung Cancer Awareness Month activities, you'll see that we have lots of things in the horizon this month, and we have listened to you all, and you've been asking us for more information to be able to become expert advocates. And we're starting with next Tuesday, November the 17th, 7 to 8 p.m. Eastern Standard Time. We haven't been able to get the world premier, one of the world premier researchers in EGFR, a fellow Canadian by training, Dr. Tony Mock and Dr. Barb Milosky, in a webinar panel called What's New in EGFR Lung Cancer. on Sunday, November the 28th, is our Evening of Hope. And for the first time, we're going virtual. And we hope that everyone here can join us in this celebration of survivorship and progress that has been made. On Thursday, December 3rd, our Lung Cancer Awareness Month is closing out with also a What's New in Lung Cancer series called the What's New in ALK Positive Lung Cancer. And the panelist is the past president of Lung Cancer Canada, Dr. Latasha Lael, and also featuring another world premier researcher, Dr. Ross Camage. So in between that time, you might think, what is Lung Cancer Canada doing between the 17th and 29th? Well, we have lots of things ongoing. And next slide, please, Michelle. We have launched our very first t-shirt design contest. So we've heard from all of you across the country to tell us that, you know what, we need a t-shirt to rally around. We need a yearly t-shirt that patients have designed. So we have heard you, and we've opened up this t-shirt design contest. So we ask that you upload your submission before November the 23rd. And we will have then select 3 finalists. You guys can vote on that. And the winner will be announced at the Lung Cancer Canada Evening of Hope. So for all of you guys who are thinking, oh, I have an idea, but I don't know if I can draw this out, not to worry. We've got some artists who's graciously agreed to help us with that and to turn your ideas into reality. So our next event is really for those who believe that Lung Cancer Canada, lung cancer patients and their families deserve a voice. If you believe that lung cancer patients deserve a voice, if you believe that lung cancer patients deserve equal access to treatment, and if you believe that lung cancer patients deserve to live, then you must join Hope Army. You are a Hope Army recruit. So Hope Army is a social media advocacy awareness campaign for us. By joining Hope Army, what we'll be asking you to do is we'll be sending you out on various missions. And these missions include missions of awareness, where we'll send you posts that you post on social media, where we might send you, if you so like, advocacy, then please, these are the advocacy points that we want to take to your elected officials and also your community leaders. We want you to be able to share with your friends that you believe that you've joined Hope Army. And so we've created a whole bunch of social media plugins to help you do that. And we've also created a whole bunch of different missions for you to choose what you'd like to do with whatever you're comfortable with. And we want, lastly, for you to proudly declare that you are a Hope Army recruit. So everyone who joins Hope Army will be getting this Hope Army mask. And we hope that you will all put it on and join us. Thank you.
Thank you so much, Christina. I know we have gone a bit over time. I don't know if Michelle has collated any questions or if any questions have come in on the chat. I do know after this, there are several breakout groups by province, so there will be additional opportunities for folks to ask questions in those fora as well. Michelle, do we have any questions that have been posed out there?
As we go to the questions, Michelle, can you just show the video that was sent in?
Absolutely.
You need sound, Michelle.
Right.
That's okay. We'll send this video out and we'll post it. I think
technology.
Age of technology. We will, if there's any questions, please post them in the chat, but also following this, we will have a various number of breakout rooms that will allow you to ask more questions of of the various leaders that are in your breakout rooms respectively. So Roz, I think in the interest of staying on time, why don't we go to the breakouts?
Okay, well, I will just take the last moments then to thank everyone who has participated today. We had fantastic attendance. Nearly 150 people logging in today to hear about our press briefing today. So if you hold on, we'll be welcoming people into different breakout rooms where we can continue the conversation in a more fireside chat type of scenario.